Are you able to share your screen, doctor?
Yes.
Yeah.
So now perfect.
Yes, now it's
Yeah.
perfect.
Yeah.
For now, you can stop sharing your screen, doctor. I'll
Okay.
just
Okay. Okay. Sure.
give you a heads up as to when to start
Yes.
sharing your
Oh,
screen.
oh, oh.
So, Ifra, shall we start?
Yes. We can start.
Yes, let's start. Hello and a very good afternoon to all the wonderful people who have joined today. This is your host, Dr. Ifra Shakil, warmly welcoming you all to today's webinar on behalf of our organization, Dentist Channel Online. I would like to extend a warm welcome to Dr. Anshul Mel for coming on board with us. Thank you for joining as a guest speaker for today's webinar, Doctor.
Thank you. Thank you, doctor.
Well, today's topic is digital implantology. PEACE, peace, wherein P stands for perfection, E stands for easy, A stands for aesthetic, C stands for creative, and E stands for effortless. So, this webinar will provide insights about the digital implant prosthetics and its role in transforming dental restoration, the components and technologies involved in digital implant processes, including 3D imaging, CAD CAM, and how digital workflows are integrated into the process of planning, simulation, fabrication, and placement of digital implant processes. So, without wasting further time, I would like to start by giving a brief introduction about Dr. Anshul. He has completed his master's in prosthodontics and is working as a digital dental expert since 2014. Dr. Anshul has 8 patents and 4 copyrights in the world of digital dentistry and has many national and international publications in different journals. He is a key opinion leader for different national and international companies and is an official trainer for ExoCAD. So, once again, I, and on behalf of our entire team, welcome you to today's webinar, Doctor. And for all the participants, I may inform you that if you have any doubts or queries during the webinar, kindly put your questions in the Q&A box below so that it can be addressed at the end of the session. So, over to you, Doctor.
Thank you, doctor, for introduction. And I just want to say everything today is digital. So our webinar is also on digital platform. Okay, so that's how the world is changing towards digitalization, and definitely implantology is also not behind of that to share it. So today's my topic. I'm going to share as a prosthodontist and implantologist, like how the digital era is help us to solve the problem of the implant placement to the end of the prosthetic. So for the patient is only prosthetic. For patient only is prosthetic. They are not going to see how you place the implant or what you have done the implant in that. Okay, so today's my presentation is like from where you have to start the digital dentistry in implantology is like from the planning to the end of the prosthetic. So it's only crown to crown, not an implant. Okay, implant will play a role after doing anything like the future building we have to plan. Before that, we create everything and then we place the pillar where we have to start the yeah, the pillar. So that's how this digital era is evolved. So me, Dr. Anshul mel, as introduction is already given, and so many things we have like working from 2014 onwards on digital dentistry. So if I ask any question to the any implantologist over here, if he place the implant and patient is waiting outside of his waiting room after 1 month or 1.5 months, is if he's seeing like his patient is implant patient is waiting or assistant told like implant patient is waiting outside. So what the feeling of the doctor? Okay, so the feeling of the doctor is like this, as you can see on a screen. like he need any this kind of magical stick. So like whatever the problem will be there in the patient mouth is automatically solved. So that is a feeling of the doctor when they are seeing the patient waiting outside the room in which they have placed the implant. Okay. So I will start my presentation with the implantologist and implant patient. Okay, so to be honest, in country like us, in which like we have a patients, okay, and they have they for them their prospect they are investing the money, not a they are doing a treatment. Okay, the prospective is different in our countries. So what they feel like they pay that much of amount. It means they need an interest every year. They will not think about the health. Okay, they are thinking like the investment, and if they invest the money in the bank, they will get the interest every year. Okay, like that the patient for implantologist like implant patient is like that. Okay, everywhere like as you can see on a screen they have married with a implantologist like this. So this is always I'm telling like the everywhere like the implant patient is like in our country is like you got married with the patient. So before starting the prosthetic work, okay, if I'll ask the first question from where you will start digital dentist, okay, in implantology. So everyone asks like from the start of taking impression and then the digital they will start. But to me, it's like before placement of implant. If you think about the patient, first thing what you will do, you send the patient for the CBCT, you send the patient for the CBCT, or you take a IOP or OPG, okay, like that. So it's everything is digital. Okay, so it starts from taking OPG, IOPA or CBCT to the giving the prosthesis till that level, because after placement also we are doing the same thing, you taking a CBCT and all. So everything is digital. Okay, so always the digital implantology will start from the taking a impression, or it starts from planning the implant. Okay, so for that so many softwares are there, you can plan, you can see, you can, if you are free hand doing the surgeries, you can have only viewers also is available in market. So from there you have to start. So future tooth you have to place, and according to you can plan it. Okay, so this is how like it is a also a huge topic, like how you can plan and how you can place a top. But for here like we have limited time, and I have to explain a lot of inside of that digital dentistry. So I will start my presentation from the prosthetic point of view, because no one interested how you place the implant. Okay, everyone is like how you place the prosthetic, how you create the prosthetic. Okay, because at the end prosthetic only give a value of your work. Okay, as I told you, patient only see the teeth like this, not the implant. So that's I think I should speak more on the prosthetic. And prosthetic driven implantology is the main key of success. So that's how I'm planning to do it. So this is the thing what we are doing regularly. So this is the normal transfer coping what we are taking for the normal implant placement manually, like the open tree impression and the closed tree. If I'll ask question like when we want to use open tray, okay, so they say more than two implants, or full large cases people are using open tray, and the closed tray only for the single implant most commonly using. But according to me, if you ask me like which is the toughest impression to take, okay, so if ask me personally, then the single implant placement and taking an impression is toughest job than the multiple implant, because multiple implant you splint it together and you are giving the prostate, but in single you require perfect position of the implant, okay, the hex position, and then only you can able to create the prosthetic. So for me it's like a difficult impression single implant than the full mouth. The same thing when you come to the digital, it's a scan body. So you have a scan body according to the different company or third party also available. Like the company is not there in the market, you can purchase from them. Like example, you have a stem noise kind of implant. You can purchase the scan body for third party like theirs, Angular screw channel, and so many options are there. The bioarchitects, so many options are there. So you can use the select the scan bodies according to your need, like what all options they are providing and what kind of connection they are providing. It is compatible or it is perfectly compatible or not, quality wise it is good or not. So depending on that. But the same way, if you want to enter into the computer, okay, you want to enter insert your patient into the computer, then you require the scan protein to enter the all data inside of the software, and it will act as a open tray or closed tray impression copy. After taking impression, the most biggest part is jig trial. Okay, so many times like I got a pulsar jig trial is fitting, but my final prostate is not fitting. Okay, because it is how you check the jig trial is most important factor, because it have a different material. Okay, and it's like a plastic material like pattern resin you're using, so there is a flexibility inside of it. If you give more pressure, it will flex and your jig trial will be fit inside of that. Okay, and then if it and final will not fit, and say like this modi hai to mumkin, kind of like ye bit raha tha to final kyun nahi bit raha, it's kind of that call I'm getting. Or maybe so many have noticed over here, or maybe if some lab person is joined us, then they have faced the same problem. So jig trial is the most important part in digital or manual, and the maximum times it depend on the doctor tactile sense. Okay, how they are fixing the screw with the prosthetic or with the jig inside of the implant, so it's completely depend on that. And then we have secondary tools like IOPA and x-rays, and then like you can take and you can check it. Okay, so most common problem is like if you have a full arch implant, then you will get this same U kind of jig. So it has a flexibility like this, you can see. So it will be flex if it is in pattern jig. If it is in the gypsum, also it's available jig trial. So if it will not flex, and it when the patient doctor is trying to fix the screw, it will get fracture because it is not perfectly taken the impression. Okay, it got fracture, and then after that he wants to repeat the impression. He cannot use that jig to take impression. He has to make a one more open tray impression, like everything he have to fix it inside the mouth and everything he has to do. So this is how like the people are doing it. So in place of that, what we are doing it, we just concluded like this. For upper we make a D shape, as you can see on a screen on the right side, and the lower we make it A shape, so we avoid the flexibility of your jig. And you can check if it is not fitting, it means there is an error in impression, or there is an error in your selection of abutment to making a jig. It's biggest sentence that I am telling you, because so many things like miss index. If I'll ask the one simple question, if you have a single implant and if you have multiple implant, so for single, which abutment you will take, hex or non-hex? So maximum you will raise hand hex. But when I will say that you have multiple implants, and which abutment you will select, to say everyone say non-hex. Why? Because the deviation in parallelism. That's why your prosthetic will not fit, and that's why they are taking a non-hex. Okay. So same question if I ask like which impression coping you are using to making or checking the jig. So they say like whatever the impression coping they have taken the impression with the hex, the same impression coping they are using to make the jig trial. Okay. And in that same case, they have multiple implants. So it is not possible. They know which abutment they have to use when the multiple abut implants are there. Thus, but they are the same mistake they are doing. They are checking, and their jig also get fit because of flexibility of the pattern resin. And they say like my jig was fitting, and now my final is not fitting. So that's why you have to use non-hex abutment to create the jig when you have full arch cases, when you are working on the implant level. Okay, if you are working on the abutment levels, okay, then you have a different kind of jig that you can use it for that particular case. And before going to digital, the basics would be clear. So some inside of basic. Not I will not take much time. I know you have had a lot proper lunch, and it's a boring time after lunch to listen someone like this. But I hope I will make you this thing interesting. So like you will enjoy my lecture. Okay, so this is the first. Always I have this question like we have huge catalog of abutment. Okay, but if you ask any laboratory person, or if you have recall your all cases, you have only used three abutment. One is cement retained stock abutment, second one is castable abutment, and third one is multi-unit abutment. Not more than three you are not using at all. Okay, but companies gain huge catalog. They are investing the money to create different solution for different condition. Okay, and more than three you don't know. So that's why I have always questioned why the company is creating this huge catalog to get the answer of my patient. And for that, the example, if I will ask my, if I call my company reseller, like how much like you charge, so you get this much of charge of your implant and abutment, and then I just book the my uh, package with the implant, and then say like you send me the straight abutment. Okay, now you have four kind of straight abutment as you can see on a screen. Okay, he will not ask you which abutment you want among four. Okay, whatever he has in the stock he will send you, and you are using the same abutment inside of your cases. So you never ask why these four design are there and what is the purpose of using these four straight abutment, why the companies manufacture the four abutment. Okay, so this kind of same question I have, and then just ask like, so what I have concluded is like you have a normal crown and bridge. If I ask like PFM, so like they will say shoulder finish line, or zirconia shoulder finish line. For metal, so will say chamfer finish line. Okay, so same way, if you are going for metal, you have a chamfer finish line on the left side, two abutments, and if you are using a PFM or zirconia, right side the shoulder finish line, you can use it. Okay, now there is a difference between first and second abutment. You can see the serration and another is completely polished surface. Okay, first sonation is there because of like you will get mechanical retention of your luted crown, so it will help you out to luting. And there is anti-rotation, so when you do a cementation your crown will not rotate and have a perfect position where your laboratory person has fabricated. But the other one have, there is no sonation, there is no anti-rotation. Okay, this abutment is specially made for the customized solution, digital solution. Okay, there is a one more area in which like you can create stock abutment into custom abutment by using a digital technology. Okay, so this is a one of the solution in which like you want to correct your angulation, and you can design that angulation the top part of your abutment in the software, and you can loot it completely with the abutment. Okay, and while looting it, it is very tight. While you design is very tight, it's like a sometimes you create the crown and it will stuck onto the inside patient, or you have to give a lot of forces to take it out. Okay, same way it is stuck on it. Okay, like this it will go. So, and because of that there is no anti-rotation and complete polished surface is there on the top of it. So like the laboratory person just tap it, so it like a friction base it will act, so there is no need of fluting cement, and it become a cold weld, and it will act as your customer one, and you can do on the top, you can cement it and crown you can create. So like you can create your emergence profile and everything whatever you want you can create it. The same way, as I told you, like if I have a crown, if I have PFM, the margins are open and there is a maximum chance of food lodgement. Here also food lodgement is there, but the slight cleansing, so it automatically cleansed by the patient. Okay, the same way you have angle abutment, so you can modify the angle and then you create the angle, because in example companies give 15 degree 30 degree of angle abutment, then it is you are not exactly 30 or exactly 15 inside the pond, so you have to do a surveying, mill it, and then you can create the crown. The example, this is a one case in which I want to create a bridge. One implant is like this, one implant is straight, so I use an angle abutment. Now the biggest thing you have to notice in angle abutment is like the path of insertion of my this complete bridge, if I am or connected crown, if I want to create it in this direction, path of insertion. Okay, but my finish line of this is also parallel with my path of insertion, but my finish line of this is not parallel with my path of insertion. My finish line is in the direction of implant. Okay, so selection of angle abutment is also most important factor. Otherwise, what happen after luting of your bridge or a crown, you will, if you take IOP, you will see the space in between the finish line and the crown finish line, like the end part of the crown. Okay, you will see the clear cut space because of this reason. Okay, so you use this kind of abutment or select the abutment from the catalog, so like you can have a same path of insertion which follow the finish line also. Okay, as you can see the finish line of first abutment and the angle abutment is parallel, so now it's resting completely on a both abutment, and then you will not see the space, and there is no cement leakage and all. Okay, so most commonly like cement return have a problem. So if this kind of is there, there is a gap in this area and there is cement leakage is also there. So this is most important point I want to tell you regarding the angle abutment, which is cement return. And yeah, it's a pre-mill. So pre-mill is the abutment in which we can use a digital era, like you can customize your abutment according to your implant. And the bottom, why it's called pre-mill, because the bottom, the connection is already given by the company, and the top part you can modify according to the angle. Example, this is a case in which we have a different angle of implant base, and now I want to do cement retain bridge, so all the top part is parallel. But the same way, you should not forget your basic. Okay, if you can see, all have path of insertion is same, but the top area, like the bottom area, have a finish line, have a different direction. And this is also the drawback of digital dentistry, in which like some of the loopholes are there, like you will not get 100% of answer with the digital things. So this is also one thing you have to keep in mind when you are working digitally. So example, the same case, if I have in my software, my top part, the cementing area, it's parallel, but if I will see the finish line, my finish line is going same way in the direction of implant, because my scan body in that direction. So the same problem what we have in the custom prefabricated one we have in custom. So we have to take this abutment onto the surveyor, and we have to modify the finish line. As you can see, the last everything is connected the same. If I'll check on another abutment, you can see the gap. Okay, it's not touching, so there is a deviation because of the finish line. The finish lines touch before the other surface will touch. So that finish line we modify, and then only you can create the bridge on the top of it, so you have perfect path of insertion with the perfect adaptation. The most important part is the adaptation of the your bridge on a top bridge. And the same way, some of the company have a huge, like this is the digital solution and this is a manual solution, which like you got a thick abutment, so you can modify the surface on a manual surveyor completely. You mill it and you can make a simple path of insertion and get the cemented solution. And then this is all I just briefly give about the cement detail, and now I'll come to the screw detail. So most common choice if we ask any dentist, like screw retail, because easy to retrieve, easy to place, and there is no issue in occlusion or anytime anything fracture, we can rebuild the ceramic on the top of it, and so many freedom, like the cleaning also we can do easily. So it's easy for the doctor. So always the first choice is screw retail. Okay, but in which we have a lot of options like hex and non-hex and all abutments are there. But if you ask your laboratory, like who is not doing digital, they will ask you to give a castable abutment. Okay. In castable also we have two options. One is completely plastic on the right side, and the tie base. Okay. So if you ask your laboratory person, he will say like, you sir, you buy tie base because your connection is given by the company, so I will get the perfect fitting, and in this the casting metal will come as your connection. Okay, so the doctor will place the order of tie base with the castable abutment. Okay, but the tie base actually only for the gold casting or peak pressing. Okay, because the heating temperature more than 700, when it's cross, okay, it start reacting with the carbon dioxide inside of the environment, and it become carbonized. Okay, so it will spoil the property of titanium. So when you are looking this kind of castable abutment, you should buy the abutment with the chrome cobalt base. Okay, so in Korean systems, most commonly you will get the combined alloy, so there is no issue you cast anywhere like chrome cobalt or nickel chrome, what commonly we are using for the casting dental industry. And the Israel system, you should ask the chrome cobalt base. They have two categories, titanium base and chrome cobalt base. So separately you have to ask when you are ordering the abutment. So this is just brief about the castable abutment if you are using that castable abutment. Now screw 10, it means multiple implants, you have to go ahead with the non-X. Okay, so what is the problem in the non-X? You can see on a screen the hex have a, like this is my inner part of my implant and this is my abutment. Okay, so there is a very minimum space in between the inner surface of implant and the hex abutment, but in non-hex there is a space in between the inner surface of implant and the non-hex abutment. So whenever the lateral force will come, there is a movement, okay, and that movement will directly transfer on the center screw, okay, because it's resting completely on the center screw. So because of that longer time the screw become bent or folded or it get fractured, okay, either it will get loosened up, or if you have bone resorption on any one side of your implant, there is chance of implant fracture also. So that's the reason like you should avoid non-hex in case of hex. In hex, you have two-person. One is inner surface of implant will resist the forces and the internal screw. So two-person is resisting the forces, which is more durability in that thing. So that's why you have to use hex. Now the question is that you have full mouth, you are not parallel. Even if I will plan it digitally, anatomy touch will not allow me to make it parallel, okay, so we have different solution for that also. The same way, just in a lateral view I'm just showing. So this is a called AR abutment from bioarchitecture company, so in which what they have done it, the internal connection is a hex as you are getting from the company already, okay, and the outer external connection is non-hex, okay, but it is a like this. So the prosthetic is non-hex. So whatever full mouth you have, you know, like non-hex is the best solution when you have multiple implant. Okay. So the non-hex is on a top and the implant connection is hex. Now the prosthetic have a non-hex, one link like the center abutment and then your implant. Okay. So inner part of abutment have a hex and outer is non-hex. So now when you insert the prosthetic and you insert the screw, it become a one part, okay, it become a one part. So this is my blue color is my prosthetic which is non-hex, and the implant the abutment, and inside of implant the hex, and it both assembly connected with the implant with a single screw. So now with implant is a hex but non-hex in prosthetic, so both advantage I am taking it in this case. And along with that they are providing the angulation solutions also. If you have a angulation correction, the 5 degree 35 degree all angles are available, so you can correct all the angulation if on a top if you want to correct. So this is the uh, one of the solution in which full mouth you can create the hex abutment and you can get all very soon. So this is a case in which like you can see the two abutments are placed over here and both have different angles and the screw return bar on the top of it. So if you can see both implant have different direction and it is fitted completely inside of mouth. And the hex connection with the implant. So this is the advantage of this abutment. But the difference between this and the multi-unit, like multi-unit have two units, like two sets of screw. In this only one screw will connect both things. Okay, so this is the one of the solution in which like you can do full mouth and avoid the screw fracturing and save the things. The same way, the multi-unit. Also, multi-units, I have two units, like one is connecting with the implant and the second unit is for the prosthetic, which is non-hex. So, whatever forces will come with bear by the hex in the bottom, example, you have angle, so you have a hex inside of that. And the top part, like the prosthetic non-hex. So, whatever the lateral force, anything will be on top. So, anything happen to the small screw or anything, it will fracture on the top. Okay, so it will not create a problem at the bottom. So your implant is always safe. So main goal is like implant. If we save the implant, we can recreate the prosthetic also. But if you don't have a safe implant, then it's difficult to create prosthetic. So that's how the multi-units evolve. And the maximum doctor are saying like multi-unit is good, as if you are like we got all the cases solved with the multi-unit, there is no problem in multi-unit. So you should full mount only multi-unit you have to do, or full arch multi-unit do. As an example, if you can see on a screen how you look the duck, it look awesome. Okay, so everyone say like yes, we are looking the duck perfectly. Okay, but if I will say from right side to left side you see, then there is a rabbit also in this photograph, but I just tell you like you see the duck, so you can see only duck. Okay, so that's how the company people are giving us like 17 degree 30 degree, just you use this abutment, that is only solution, because they cannot create the customized solution. And because of manufacturing cost is going to be high and it's difficult to handle all the clients, so they are just giving this is best and you have to use that. Okay, and that's how we are. And everyone is facing the problem, but what they are playing with our mind is like वो doctor तो कर रहा है ना, that doctor is doing already, so why you are facing? So there is a problem in doctor, there is not a problem in the concept. So that's how I just use this photograph, like you just see the duck because I told you like you see the duck. Okay, there is a rabbit also in this photograph. So you, whoever seen this, notice this rabbit, you have to speak this is a rabbit. Okay, you can text on a chat box like this is a rabbit. So like I can understand you know the problem, but you don't have answer for that. So that is good for me for this presentation. So example, if you have a four implant on a screen, you can see only one implant is offbeat. It's like multi button is only offbeat. So what happened? Like if I'll fix it, so it will fit because the multi-unit have a conical surface. Okay, so it will like this, cap to cap. Okay, but if you have noticed, our prosthetic is not fitting on a conical. Okay, our prosthetic fitting on a finish line on the end. So when you fix the screw with the prosthetic to the implant, okay, it will start adapting to your finish line and it will create a space over it. And I'm sure so many doctor have or who is attending our this webinar. Okay, they have seen this or feel this, but what they are doing other side, they will just press it and fix the screw, and it will fit the screw in that side also. Okay, but the number of rotation will be less and it is active. So what happen after long time, the long usage, this main implant which got fractured, the internal screw, because the all load will taken care by this, and this loosen up and it will loosen inside of patient mode, and it will get fractured. So once again I will share you. So this is the fitting, so it easily fit. But when I will start inserting the screw, the main game is start from here. Not just placing it, it will fit because it's conical. Okay, but like you have water cup to cup, it will fit. But when it's fixing this, it become active. So for that, Pathfinder is one of the solution. I will discuss later part of the solution of that. But the in the basic, if I have a cement retain, I will select these three most common solution and the screw retain. I will use these three common solution to get my patient work easily. So this is just idea like before starting a digital, the abutment, because abutment selection, the basic is most important than doing the digital. Like the some of the doctor calling like people are saying you scan it, it will give everything perfectly and no need to worry, it will fit. It is not like that. If you scan it or if you take a manual impression, both are same, but selection of abutment is most important than doing the digital things. Then the second choice of material. Okay, the first is abutment and second is choice of material. So for immediate loading and delayed loading. So for immediate loading, we have a cable straight bridge in Surat. So wonderful bridge, and the concept we made it from there. The fibers used to create the cables are the glass fibers, so it's available. And immediate loading is a demand. Okay, so immediately you have to give a prosthetic. So like you have a lot of theoretical things are there. I don't want to discuss about that, or lot of debate also is there. Okay, so I don't want to go through it. We are believing in immediate loading when we have full arch cases, and we have it's working well when you have a good torque. Okay, so this is a case in which like you don't want to waste the time. You want immediate, like the same day you want to finish or next day you want to give a prosthetic. So just take an impression, make a there is a one strip of glass fibers available. Okay, that you have to just wrap around onto the abutment and just cure it with the light, so it become more hard. Okay, and then you send it for the acrylization or do a jaw release in mount and then go for the acrylization. So like immediately the next day you can fix the prosthetic which have a base structure inside of it. The same way you have a diacom, the same way the glass fiber threads are available, you can use it. Or the aluvex kind of sheet, like you are using aluvex, the U-shaped sheets to take a bite. Okay, same way this carbon fibers material is there. So for the U-shaped sheets are available. You place it on a cast, make a hole, and lute it with the resin cement with your cylinders, temporary cylinders, and you can give a prosthetic. So like you can edit it according to your prosthetic. You check the bar within hour, and then you go into the acrylization or next process. So the faster you can work. The same way if you are planning your case, so you can create the metal bar like an impression tray. You just create the tray kind of structure according to the shape of your patient reach, and tentatively canine and molar you are planning the implant, you just create the hole in your metal frame and just keep ready. So like once your implant placement is done, like this, if it is ready before surgery, when the implant placement is done, you just lute it and you can edit wherever you want to edit, and the fix the build prosthetic on the top of it, and you can reinsert immediately. So same appointment or same within hour you can deliver the prosthetic if you have prepared the things like this. So this is the three basic option we are using for immediate loading if you want to do it. And the delayed loading, you know everything like the in like the three division, like from the occlusal plane to 10 mm to the crest, like from on the back side, not the anterior side. So occlusal plane to the crest of the reach, it should be 10 mm, less than 10 mm, more than 10 mm to 15 mm, and more than 15 mm. There is three division. Okay, so in this, this is a solution we are giving. If it is more than 15 mm, you have huge height, so you should use acrylic. You have sufficient height of acrylic, so it will not get fractured, and your lightweight or your titanium bar or hollow titanium bar or the large PP or PEEK material on a thimble crown on the top of it, the zirconia crown on the top of it. So you can reduce the weight, and you can maintain the longevity of the prosthetic as well. The same way, if you have a 10 into 15 mm, in most of the Indian population will land up in this condition. So PFM is the best choice of material, and followed by the PEEK material and the top of it, or the metal zirconia, like the metal frame zirconia, or you can do it, or you can use a direct zirconia, but we avoid in full arches, but single like half arch or the 3 units we direct given zirconia with a tie base, which is available in the market. So this is a thing. And the less than 10 mm, when you have very less height, direct metal or direct barge PP material, it's available in ivory color, you can give it. Or some of the cases we are using thermoplastic material, like what we are making a flexible denture. So it's a repeatable material, like 6 months we have to replace. It's all about absorbing the saliva, as you know. But the advantage of this material using the when you have a less mouth opening, like there is less, like you have a fibrosis on the side, we place the implant, we place the prosthetic. But why we need this? Because patient is using mouth opening device. Okay, so it create the forces. Okay, but it's a thermoplastic, so it will bear the forces and it will not get fractured because of the forces. And even though this kind of patient having the food, they have less mouth opening. Okay, so that's why they will get a lot of forces to have the masticate the food. So that's why we are using this bar dentoplast material to this kind of cases, which is from the pre-dent to color thermoplastic material. So now I should start my journey to the digital level, like from this to this, like how you can start your digital journey. So if you start the journey for the prosthetic part, you require the first part is scanning. Okay, so if you scan the case, then you can enter the digital era. So first part, like the scanning. Okay, so if I'll ask how many of a scanner, so maybe 50% of the doctor will say yes, we have a scanner. But if I'll ask how much, what is the life of your scanner, from the 50%, 5% also don't know how much the life of the scanner. Okay, it is not like that you invest the money once, it's going for the lifetime the same scanner. The scanner also have life. Okay, the light, any gadget have its life. Example, you have mobile. Okay, the mobile also have its life. Okay, more than that it will not work, even though it is working well. Okay, but your software is upgrading. Okay, so it will not support your mobile. So same way the scanner also has its life. So as you can see on a screen, minimum this much of screen frame should be recorded inside of on side of when you start scanning, the minimum frame should be like that. So you can increase the life of the scanner. Number of scanning is more then the frame more, then your life of the scanner will be less. So it is, some of the doctors just they are scanning to educate the patient. Yeah, you should educate, but you include the cost of the scanning. Okay, because the scanner also is life. And how the scanner is working, like it's throwing the light and reflects, and it captured by the sensor, and it's working. So the same way, like when you have scanning, it should be in sequence. So like it will capture, the sensor will capture all the images, and it creates single image at the end. Okay, to display you. So the sequence should be follow the previous slide. Okay, so your hand should be stable while scanning it, and it should record perfectly. It should not run like the second sequence on a screen. So you will get some holes, and the software is doing their own uh, things behind it and give you the image, but it's not exact. Okay, so it should be controlled scanning. The same way, the angulation of your patient, like when you have a lower, you just upright the patient and scan it, and when you have a upper, you should make a supine position and go back side of the patient and scan it from the back side of the patient. In lower, you are in front, the operator on the front, and for lower, the operator on the back side. So this is most easiest way to scan the thing. So like you will get the image in a one shot, image in a one shot. Okay, so that's how we can do the scan. And yeah, it's an indirect vision. Okay, so either you should completely inside of the patient and your assistant is helping you, or you are completely outside and see you are not hurting the patient, because it's an indirect vision you have to do it. The most important is like your chair light. As I told you, the reflection is working on reflection, so your chair light should be off, otherwise it will create the image as you can see on the screen. And the four different sequence, but all have different advantage. Most commonly what we are using it like, if I have upper, I will go back and I will start scanning from the back side and try to capture everything in one shot, maximum area in one shot. So when I will do occlusal, I will just place my scanner and just little movement up out, like rotation movement I will give to scanner. So it will capture maximum area of occlusal as well little area of buccal and lingual side. So like when I will start buccal side scanning, I have a reference, so my scanner will start scanning faster on the buccal side and the same way on the lingual side. So that commonly sequence we are using. Why we are backside of the patient while scanning mentally? If I'm a front side, so half of the arch I will scan it, then I have to take out my scanner and then other arch I have to go. So it will create the stitching area is very less. So we avoid that because we want the single arch scanning in one shot, which give a better result in the output. And the same thing, if I will ask like which is best among these two, so what you will say? Like the color one. Most commonly people are seeing the things on the color one, the things they are seeing and they are sending to the lab. But if you can see, there is a lingual area. Okay, it's you are not able to see the clear cut margin on a lingual area. Okay, so always send the case to the laboratory, or if you are going to use in-house digital dentist, you see monochromatic your scan, check it out in monochromatic, and then you go ahead with your next part. If you can see the same scan, if you have a monochromatic, you easily make out there is a double scan, not a single scan. Okay, in color sometimes if it's nearby you will not make out the difference between that. Then the context. Okay, sometimes the context you cannot able to scan it on one side or the other side, so it has a dual scan technology in which like that part of small just to make a putty impression. They just press it on that area and take it out. Remaining part you scan it with the scanner. One project we got it over. The second project you open and scan the putty impression, scan with the putty, that half of the putty like 3 teeth ahead of that area, scan it and send it to lab. So what lab people will do, the main data on that they will superimpose your putty impression, so they will get the perfect contact of that. Example distal of 7 you want to do, or the contact area, or we have a lot of recession case in which we are doing the same thing when we are not able to scan it. So it's hybrid. So always when you have a doubt. And the same case, if you have an impression, if you take impression, you pour the cast, when you take out, it will get fractured because of undercut. Okay, so your technician is looting it out. So the disadvantage of manual we can correct, and disadvantage of digital also we can correct with the hybrid. So this is the things most commonly we are doing. The same thing when you have a lot of bleeding. Okay, so we face the same problem in the bleeding cases. So in this we take impression, we scan impression and send it to lab. So both errors are we can skip by the digital and the manual. Okay, and the second thing like the isolation or saliva. Okay, then in which we just put a gauze piece like your palm shape, like complete long, and we keep it inside the mouth. Ask patient to close the mouth for the 1 minute. Okay, and then we are ready with the scanner. We take out the gauze and immediately start scanning it. Okay, and why? Because piece of gauze piece is like, because we don't want the threads. If I'll cut a small like most the doctor at cutting a small gauze piece to stop the bleeding or on the particular area. If I use the same side, that the threads will be inside of mouth and it will interfere in my scanning. So that's why I need a long, like complete palm shape, like the longer one. You cut it off from your roll or gauze, like like gauze piece roll, and then you can place it. If I'll ask which is best can among these four, so most of the time, like people select the left side, the color one. But if you can see in the monochromatic, okay, there is a rough surface, everything you can see, but in color you will not identify that effect. So that's why I have just put some of the images. The same way, your preparations, like here and here, you will not make much difference, okay, as a naked eye. But when you see the monochrome, you can see all roughness, and here is a completely finished surface you can see. So that's how you have to check your scan in monochromatic. Sometimes you have done everything perfect, still your scan is rejected because you missed the future why you need the integral scan of this case. Okay, example, this case in which I want to create a bridge, I send it to the lab and they have rejected my scan. Then I say, oh my god, what happened? So they say like my future quantic is going to be here, and I didn't capture that area only. Okay, so they have to design that things in the app, so it's create the problem. So important that also which area you are capturing and what is your future, like what you are planning for the future. So this is some tips for the normal intraoral scanning. The most common problem is like scanning the occlusion. You have upper arch, you scan it, lower arch, you scan it, then you have a third is occlusal scanning. Okay, so after occlusal scanning, your cast is like this. What you mean by this? My gray color is my lower cast and brown color is my upper cast. When my software is up, like superimposes with the byte, what I have scanned, I got this. Okay, so what is indicate? It indicate is like my upper teeth is going inside of my lower teeth. Okay, now you can see on a back side I am seeing it. Okay, it's going inside. It means there is a problem in occlusion scanning. Okay, so once you scan your occlusion, you check your scan files up there from the back side. It's not going through the uh, that reason. So that site you can check it, and then you scan it. How to modify it? You cross that byte, you start rescanning of the byte, okay, and you place your one hand on the message of the patient and ask patient to intentionally clench it before start scanning it. Patients clench it and then you say like relax. Now you feel the message is relaxed. At that point you start scanning of the occlusion, and then you will get the perfect occlusion uh, inside of these kind of cases. Because when you scan upper arch, PDL is relaxed state. When you scan a lower arch, PDL is relaxed state. But when you ask patient to clench it, your PDL is clenched and your teeth are rotating. And software is seeing some of the reference start superimposing. So you will get the wrong data. So that's how you can correct the data as you can see on the screen, and then you send it to the laboratory for the next process. Wow, this is a one more good case which I got it. This is a uh, lip cleft palate case in which like they came to the us for the full like upper arch rehabilitation. Like, and we have seen like there is no bone in anterior region, it's hanging pre-maxilla. So now the most common question which I am getting is like, doctor, we have cases, we done mock-up everything, digital mock-up we have done it. Now we want to give a same occlusion in a final, but we already prepared everything. So now how I will superimpose the same occlusion or give a same occlusion in the final. So for that questions, this case I am just putting it. So pre-maxilla is hanging, so we just virtually extract and we done a mock-up for that case. Okay. So this is a PMMA mock-up for the case. So we just loot it before preparation. We loot it inside the box and ask patient to use it for 20 days. Patient is happy for the functionality and speech and everything. Now doctor wants same occlusion in final. And as you can see, if the two preparation is done on this top of this, we lose everything. Okay, so we cannot give same occlusion in final. Okay, so what we have done it, we place a mini implant like this, the orthodontic implants onto the area along with the prosthetic. We scan it. So now I have a upper arch with the prosthetic and this pin, then the lower arch in occlusion. After that, we start preparing the tooth. Okay, after preparation is what we have a prepared tooth in this scan, and the scheme my mini implants are there on the top of it. Okay, so now what I can do it, I just superimpose this post-operative cutting with the pre-operative mock-up using this pin as a marker, and I just superimpose it. So I will get the perfect occlusion in my final. So this is my superimposition point, so I can get, and then I will start designing of the same bridge what I have given to the patient, and then we insert. So this is a preparation, and this is the frame in which in this case we have used it because this is a huge bridge, and PFM is difficult to build a PFM because anything happen in future, the crack or anything fracture, it's we have to cut everything and you have to take it out. So we use a metal zirconia bridge. So metal we create titanium, so we can reduce the weight. Okay, and the hollow from inside. Okay, and the zirconia, okay, on the top of we loot it out inside of laboratory, and the complete bridge we loot it inside of mouth. So this is a complete prosthetic to the patient. So anything happen to the zirconia, we can take out the top zirconia, we can keep my bar as it is inside the mouth, and then we can reload the new prosthetic which we have stored data. So this is one more advantage of digital. One is maintaining the same byte. The second thing is like the futuristic, like we have a data, so we can use the same data for the future prosthetic if anything happen, and the natural things are the same. Okay, so we can use the same data for the future. So this is how we create the bridge, and this is a post-operative the same case. So patient came to us without smile and a smile. But the most important thing is like the smile of the doctor. You can see the smile of the doctor is more than the patient because the same occlusion we have transferred without any problem or without any hassle, without multiple impression, without doing things. And that in this case we have pre-maxilla, so it's hanging. Okay, so difficult to take impression. So all thing we have sorted out within a 3 appointments. So that's why this most important thing, like the doctor is more happy than the patient. So this is a case in which like we have a long edentulous area in which we want to scan it. So earlier stage we used to do the composite like this kind of area, and then we scan it. So my scanner will not stop because there is no static structure when you have long scanning area. But nowadays we just put a composite balls in between, so like easily scan it. So we mop the gums with a gauze piece, so it become a dry, and then we flow the composite, flowable composite, and cure it, and then scan it. So if you lose the reference, you can go back to the previous point, not to the till the end of the tooth. Okay, otherwise you have to go till the end. To then you have to restart the scanning of the soft tissue. So that's how you can do the things in a long span edentulous area when you want to scan it. And the remaining part is we have provision in software, you can edit. Okay, this composite we can edit in the software, and we get the perfect profile of the gums. And just the sterilization protocol, and the just this is a one small tips, like if you want to clean the tip of your scanner, you use these wipes, so it will not give you any layer on backside. Example, if you use a spirit or the isopropyl alcohol, when you clean it, it will leave one layer of on the top of it, and it blur your mirror. Okay, example, you are doing immediate loading your blood, and you start scanning, and your blood will onto the your glass of your scanner, then you clean it with this. Okay, it will not leave any thing on the backside. So this is a thing you can use it for the cleaning of the tip of the scanner. Now the same way in implant, so we have freehand guided implant placement and immediate loading and delayed loading. The four divisions are there. So we'll start with a freehand or guided delayed loading. Okay, how you scan. So normally we place all four scan bodies, and we directly scan it when we have upper. But the maximum time we face the problem in lower because of the movable tissues. There is no attached gingia, so surface starts stuck in between when you start scanning. So what we are doing is we just place my scan body and use a floss to wrap around, or rubber band like what we are using for rubber band We just use a rubber band to tie all the scan body and then start scanning. So in between scan body, there is a reference of the scanner or as a rubber band. Okay, so it will not stuck and it will start scanning faster. Okay, so that's how we do. But the cases like we have a like foot pedal or the reconstruction can where soft tissues are more like it's moving continuously with the tongue. So in this, what we are doing it, we clean the scan body. We use a global composite or the pattern using to connect it with other, and then we flow the light body. Okay, and then we scan with the top part, and we take out complete assembly from the mouth and from scan it from the back side. So from back side we get a soft tissue, and from the front side we get a scan body position for the implant. Okay, so like this we can do it nowadays. Like my doctor is not happy, or they don't want to spend time to scan a full arches. So what we are doing it, we are just pre-operative. We just take a impression and create the denture base, not a impression tray. I'm telling the denture base. Okay, both upper and lower denture base we created. And what we'll do on a day of impression after placement of implant, we just place a scan body. We place the denture base and we create the hole inside of denture base, and we just hold it inside of mouth onto the gums, and we just glue the denture base with the scan body. Okay, and then we take out everything and send it to the lab. Okay, so like the lab have a denture base with the scan body inside of that. So what lab people will do, they will just place the analog on the back side. We flow the composite, sorry, silicone, gum silicone, and pour the cast, and they will get the complete the tissue surface from back side, and from top side they will get the scan body. Sorry. So that's the things what commonly we are doing. So it's easy, it's faster, only 5 to 10 minutes you can finish off the full large full mouth impression taking. And the same one more advantage, you have already denture base, and if you are working on multi, your scan body is smaller, so directly you can take impression or jaw relation. So same appointment you can finish jaw relation as well as impression. So both things you can. The third thing is like you take out from the mouth and you can reinsert it. If it is going perfectly, then your jig trial also got over on the same appointment. So impression taking, jig trial, and jaw revision, everything going to be finished on the same appointment. So that's how we are doing in nowadays for the cases when we have full heart. So no need of 3 appointments, and no need to wait my digital model. And once my physical model is ready, it's already fitting. But if I want to get the digital model, my model is ready, I can check my jig on the top of that also. So I have one more provision, I can cross check on my model also. So this is the things we are doing for the cases when we have more lot of soft issues are there. So this is a software play. So this is a top part, this is a bottom part, we superimpose. So the bottom part we get it from the gums, we will get it from the bottom part, and top part we get the scan markers, and we can start designing. The same way, if we are doing the digital this one jaw relation, we create the marker inside of that. So like this, so we create the occlusal rim, and then like this, on the top of that occlusal rim we adjust the bite and we rescan it with that. So we have a marker in a new scan in which we have a occlusion we have recorded, and we have a pre-operative on which we have designed a denture base. So like everything I can superimpose both the files. So now I have a pre-operative cast with the scan body and denture base with the marker and the jaw relation, everything in one scan one side, and I will start designing. So my mounting, my scan body and gums profile, everything I got, so I can create directly the prosthetic. The same way we have done the single piece implant case in which like difficult to take impression after welding. Okay, so we just do scanning, and then we do the same jaw relation and we can reinsert the prosthetic. So that's how we can do. Now one more step ahead, like doctor wants to mount it. Okay, it is everything is now in software, but they need to check it on a physical articulator. So this is in which like we make a denture base with the marker, and we use the face scanning technology. So directly jaw relation we scan it from the patient mouth. Okay, and then we mount it on a virtual articulator using a special face board. So one step is like the face board, we scan it. The second step is like the occlusion, we scan it, and then both we merge and create the single file that we superimpose inside of the software. So So there is a one path for that what we have created. So directly you can mount inside of articulator. So this is the digital mounting and this is the physical mounting of the same case. Right side the physical, left side digital. The same way we design inside of software, and we can check it on the articulator physical and we reinsert it. So this is the case of zygomatic image which I'm going to show you the placement in the end. The same way freehand. Okay, the freehand you place like your previous denture is ready. You pick up the impression with the abutment and you are giving. Now you can send it to lab. Now patient is happy for 3 months. Like there is no issue. Now you want the same midline and occlusal plane for your final or the delayed loading. So what you can do it, the prosthetic inside you just mop the pallet, you place the composite wall, flowable composite, cure it, and scan it with the prosthetic. As you can see now, a prosthetic and the marker inside of that. And the second scan it with you take out the prosthetic, place the scan body and scan it. So in both the common part is my composite. So I can superimpose this scan with this occlusion and I can get the jaw reason. So like this. So this can have a scan body and this can have a prosthetic. So I can superimpose onto it. This can I will superimpose over here. So I will get the jaw relation, scan body, it means implant position. So I have midline, occlusal plane, everything I got. So I can directly start fabricating my prosthetic. The same way, if you have done a bone flattening, like the cases in which like we have done flattening. So after 3 months, there is a chance of recession like this. But you want to use the same technology for the final. So we just do the flowing of the light body below the prosthetic in this area, and we take out completely and just we place a lab analog and just pour the cast. So that's how you can finish off your first part. So in which your impression is got over, your occlusion also, your prosthetic you can mount it and you can finish off the things with the manual technique. If you are going for the digital, then the special scan bodies are available. It's called analog scan bodies. You fit it inside of the prosthetic, it scan it from the back side. Okay, so it will work reverse. Okay, like your connection will come up like this. So you will get the prosthetic, you can design it, and you have midline occlusal plane, so you can directly start designing your prosthetic for the final. So that's how the analog scan bodies also is there to use it. So this is the post pre-op and the post of the case. And yeah, we are doing a lot of reconstruction cases in which it's very difficult to take impression, like orbital cases or ear or nose. We have placed implant. It's very difficult to scan with the scan body with the face scanner and all. So what we have done is we created the radio opaque scan body. So we fix that scan body and send the patient for the CBCT. Okay, and then we get perfectly the position of the implant. So this is a case in which the congenital missing here, and this is a jig for the implant placement, like where we have to place the implant. So we done a jig with the help of teeth. So the on a face only structure is teeth which connected with the bone. Okay, so we take teeth as a reference to create this jig, and where the future ear going to become, we place the future ear as you can see on the left screen, and then with the marker. So we place the marker and we send the patient for the CBCT. So like we can plant the implant. So after CBCT, we plant the implants in that area, and then we place a guided placement. And this is the after placement we place a scan body. We scan it, we design the bar and the screw retain prosthetic, and we design the ear, and then wax printing we have done it to convert it into that, and this is a final result of that. So that's how we are using a radio opaque scan body. So like you get everything inside of the scan. The same way, the CT scan nowadays we are using for reconstruction, we customize implant as well as creating the obturator. Okay, we get a soft tissue profile as you can see on the screen. You can see complete face of the patient. Okay, and that is from the CT scan. Okay, there is no MRI, nothing. And this is how the technology evolves. So like we can use this completely to design. And in this case, because of less bone, we may create the customized implant along with that the obturator. So everything is ready, like implant, the bar, the obturator before surgery. So on a day of surgery, we open the flap, we place the right implant, left implant, screw the bar and fix it. So the CT scan also a major role nowadays going to be taking an impression digital way, and you can design a lot of things as you can see on screen. So this is the same patient immediate post-operative after placement. So everything is completely resting and defect also get closed with obturator which is prefabricated before surgery. So implantology is like immediate loading. Every the patient like even so many clinicians is listening this webinar, they are also agree with this. Like patient, if patient is identified from last 5 years, there is no problem. But once he decided to to go for the teeth, he needs everything is emergency. Okay, and so many concept theoretical is there. Like we have a lot of advantage when we have multiple. I don't want to go through it. Okay, because the practicality is like we can get a lot of good result if we do a immediate loading. Okay, so this is a thing as a clinician I want to share. In the theoretical we can speak more than 2 hours on the only immediate loading, so I don't want to go on that. But the patient have only two condition. As a clinician I'm as a practitioner I'm getting is like he decided to go for the implant placement now. When because he want to travel or he want to go to attend a marriage, but last 5 years he didn't travel or he don't want to attend the marriage. That is the condition most commonly we are facing. So the practical point of view, like the clinician point of view, yes, immediate loading is most important nowadays to convince the patient. Okay, and the same way like I told you the condition in which like we need the immediate loading as you can see on screen. So this is the condition when the immediate loading is necessary. Okay, and yeah, for as a dentist also you will get immediate money because you are given everything on the same implant day of implant. But but the all implantologists like this. Okay, they want to place the implant, but they need some magic. As you can see, the red t-shirt is the prosthodontist and the blue t-shirt is the implantologist. Okay, now we just want to place the implant without planning. Okay, just seeing the CBCT, just place the, it's called brain driven implantology. And after that he wants the perfect goal, like perfect prosthetic, what the we can see in articles like completely aesthetic and everything. So that is not always possible and they need this kind of magic. Okay, so it is not possible always. Okay, maximum time they will place the implant and we have to play a lot of load as a prosthodontic to correct the things. Okay, so I hope you should use the digital technology and plan your cases. Don't wait for this magic because 100 cases, one or two cases you will get this kind of magic. Okay, so always they are in search like what kind of solution will get, so like we give a implant placement and the prosthetic on the same day. So we have a lot of solution in house 3D printing and immediate loading, like also in the same way partially edentulous. So first part is like I will start with a single tooth. Okay, so this is a guided surgery, so you plan in the software which implant you want to place, and you have three parts are ready before surgery. One is the bone, like you can like do a mock-up surgery. Second part is a pickup prosthetic, temporary prosthetic, which is ready because in single implant you have tie base, you can loot it on that. And the third part is guide, so you can place the implant through the guide. You can pick up the prosthetic with the reference of adjacencies as you can see. Okay, once you pick up, you just cut the buccal area and occlusal area, so it become like a Maryland bridge with the connection. Then reinsert and fix the screw. So for single tooth, we always prefer give a very Maryland wings because the tongue have a lot of forces. Occlusal forces it will bear, but the tongue lateral forces by the tongue, it maximum chance it will give lateral movements and implant got fail. Especially in anterior upper region when your central incisor, lateral incisor, tongue is pushing it every day like teeth the like kind of word, it pushing it outside and it maximum chance it will come out. Okay, so in this case, we give a Maryland bridge kind of bridge with the connection of the implant. So this is a case in which like single piece implant placement, we pick up the abutment and reinsert. So everything is done, and so maintain the profiling of the gums the smile, everything, and the confidence of the patient. So we can do same thing in a one day or the same appointment. So that's the one solution we are providing as a digital dentist. The challenges in single cases, like so many challenges are there. Example, you have a lab like central incisor, your coronal crack got fractured and your label circle is intact. Okay, and now if you extract that root piece, there is a resorption of bone over there. Okay, so it's very less bone to place the implant. Or you have a single molar but you have 6 mm of width of the bone. Okay, now you have to select where I have to place mesodistal buccolingual. So most of the time, if I am going freehand, I open the center of the ridge, I will select and place the implant. But my center is like this. It's my antagonist is little buccal and my center of my arch is little lingual. So my implant is lingual. So in that condition, in place of 5 diameter, I will take 4.5 and make it buccal, 5.5 mm buccal. So like the force of the antagonist on a functional cusp is resting onto my implant. So that kind of challenges you will face it. And to be honest, if you go ahead with the digital, you will get so many piece while doing it, and as well as aesthetics. So that's why I given the name of piece. So the challenge is like the partial extraction therapy, in which like you have to create the buccal shelf of your teeth and you want to place the implant on the palatal side. So like the buccal side, resorption of bone will be not there and it will stay for longer time. But the problem is that if I will do the same thing in freehand, so I will cut the tooth in a two section. Buccal sac I will take out and start implant placement. So I will go more palatally, and there is a bulge in the prosthetic while giving the end prosthetic. So in that condition, we create a special guide in which like we give a profiling of the implant like this, and then we create the complete uh, place the implant. So like I will not more buccal, no more palatal, and there is a speech between the shelk and the implant. So like it will not create problem while healing. And while inserting the implant, it will not pop out your scalp. So everything you can plan in software, the placement of future implant, and then you can fabricate. So like you can avoid the screw channel opening on buccal side. That is one more advantage of planning. So these are four parts. I will just explain the first part is the center of the tooth. I am just drilling, so I will get the perfect path for my final prosthetic. So like for my implant. So what I have decided the implant position, I will get that sent from the center. Then my distal guide, so it will create puncture on side of the tooth on the distal side, then the nasal side, the puncture on the nasal side. So now I have three reference. So then after that I'll just connect this three with the drill, sectioning drill, so it will become like this shape. So I have this complete profile. So I will have a scope, like I can take out the palatal structure and then insert the implant through the guide. So I will get the perfect profile of the case. So this is, you can see we have protected the label wall of the implant. And yes, the doctor have done a wonderful job. They have done a pick-up of mock-up of this case, and then they have transferred so they can maintain the hygiene and the profile, everything, the smile, the confidence of patient. So that's how the piece stands for. So after that, yes, definitely patient as well as dentist both have peace in the mind. So the patient have a beautiful smile and do it. So that's things are going on for the single implant cases when you are going for digital. Maximum time when I got the cases, it's like a full arches. Okay, we want full arches. Single, so we are managing, we want full arches. But single also have a lot of challenging cases. If you plan it, if you see it, you will get the challenge and you can solve it easily. Otherwise you have to face while you are fabricating the prosthetic. So before going for the next, it's a smile, wonderful smile you can see on a screen. So you can differentiate the smile. Okay, so any guesses for this smile? Okay, then I will tell you, like this is nothing, just I just want you to see, like I want to keep you awake because I can understand this is afternoon time and you are listening the things which is you are not practicing regularly. So this is nothing, just you wake you up, just a small joke, okay, for you. So like you make you little bit refreshment of that. So I'm going to start the one case in which we have planned a smile design, as well as the implant placement and immediate prosthetic. Okay, so this is a 3-in-1 guide in which we have my prosthetic, everything is ready before surgery. So this is a case in which like we have a deep bite in anterior region and posterior occlusal plane is going to be correct, like, and there is no VD loss, no vertical dimensional, I will raise the bite. Okay, so what we have planning, as you can see on the screen, the posterior plane is perfect, anterior is completely, pre-maxilla is completely done. Okay, so we have planned the case in which like we want the future smile. So we we plan case and this kind of future smile we need. So from here to here we have to reach. We place the implant in the software, we plan everything, we future teeth we call inside of planning, and we see like there is a scope of bone flattening, and we can do this kind of we can give this kind of smile as well as the structure to maintain complete occlusal plane of the final prosthetic. So this is the plan we have done. So in this we require the bone flattening guide. As you can see on the screen, we have we just use this bone cutting guide, so like my future teeth will not interfere in this bone, and we can cut and then we place the implant. So this is the first cutting guide. So we extract the tooth and we cut the bone till this level. So after bone flattening, it's look like this. Then there is a drilling guide which is screw retain on a first guide. It's a base guide. Okay, so my first guide inside of mouth and it's screw retain the drilling guide on top of it. We drill it, we place the implant. After that, we just take out the top part, which is screw retain with the bottom part. So still my base guide inside mouth. We place the abutment. Okay, and then we pick up the prosthetic with the reference of this base guide. So we place a cylinder and then we pick up the prosthetic with the reference of base guide, so it become perfect what we have planned it. Then in this case we have used the acrylic prosthetic, okay, because we have natural posterior backside. So we take out, then we send it to the lab. So the lab, the extension will cut off, and then they use complete prosthetic to mimic into the zirconia. That is, in software you can make a photocopy of your prosthetic. There is an option in exocad, so you can, so they have just mimic the same prosthetic inside of the lab using a lab scan body, and then you deliver on the next day immediately. So we post operatively immediately next day we insert this prosthetic patient. So we maintain a complete occlusal plane as well as we avoid the deep bite problem and the smile. Okay, so we maintain a perfect smile of the case of that, and this is the complete case in which bone flattening, implant placement, and the permanent prosthetic we deliver onto the 24 hours into 24 hours. So that's how the case in which we can plan it. So this kind of stuff you will get with the help of digital dentistry. After seeing this cases, my edentulous hero, as you can see on the screens, they also want some solution. Okay, they want everything on the same day because they don't want to stay after extraction for 3 months, and they want to have the food. And you know, like the Indians are food lovers, so for that also we think like we should give some solution for them. So we start giving the solution as was commonly people are doing, like the denture is ready, they will pick up the denture and we reinsert on the same day, as I have already explained in the previous uh, part of my presentation. But now we have a 4-in-1 surgical guide in which my prosthetic, my drilling guide, my implant, everything is ready before surgery. So for that you require only CBCT with the denture with the marker inside of patient mouth. Okay, if it is edentulous, if it is dentulous, in occlusion you have to give the take a CBCT and upper arch and lower arch cast or interval scan. This thing requires, so everything is planned in the software, and along with the prosthetic we deliver the to the patient, sorry, to the doctor. So on a day of surgery, I will just, this is the part of guides, but I will directly jump to the surgery so it is for easy for you to understand it. So you have 4 parts. So first part is, or this is a clinical case in which natural teeth are present. So we have to extract the tooth and place the implant. So many implantologists agree like it's difficult task to get perfect implant position after extraction. Okay, because everywhere you have a socket. Okay, so this is a guide in which we place the implant in a socket area, and we place the prosthetic as well. So this is the first part, the orange color. It's like a splint, like what we are TN the splints are well, like a splint, but it is screw retained with my base guide. Okay, so in this I'm not going to open the flap. Okay, the only area where my teeth going to be extract it you can see clinically after that. So the first part is orange color part, it's splint, and the base part is screw retained with each other. We take a reference of teeth, we fix it, and then we use an anchor pin to stabilize inside of mouth. Okay, you can see, so like in the reference of tooth we stabilize it, we take out the screw of orange part, we take out the orange part from the mouth, so we can see all the teeth, we remove all the teeth. After that, still my base guide is inside the mouth, we place the drilling guide on the top of it with a screw tape, the drilling guide, we do a drilling from that completely using a drilling guide, and then we insert the implant, place the cylinders, and we pick up as you have seen the previous case, we pick up. But the PMMA what you have used it inside of this case is long term PMMA, and upper and lower both have a same material, there is no natural teeth. So we use a long term 3D printed resin, it's crown and bridge long term fabricated which zirconia particles inside of that, so it give a good strength to the prosthetic. And what we have started and what we have finished of that case, and deliver the prosthetic on same appointment, that is the main thing of that. So there is no pressure to take impression to a jaw relation everything. Patient is also underwent the surgery and lot of trauma, so it's not giving perfect jaw relation. There is nothing to worry, and you will get the perfection in your prosthetic part. So this is what we have planned and what we are watching for the case. The same way, sometimes so many doctor, if you ask, they will say like we have a case in which board, but they don't have money. Okay, and some of the cases like they have money but they don't have board. So this is a more common slogan by the implantologist. But sometimes, luckily, the God will give you a gift. This is a case in which he has money as well as both the things. Okay, and luckily, doctor think like he should go with the guided surgery. Okay, so this is a case of Dr. Abhishek Kavlikar. So from Hubli. So he's from Hubli and from Surat. So distance case. I didn't see the patient, and patient didn't see me also till today. Everything is got over because of digital technology. So he sent the data with the denture as I told you with the CT scan, and we go through the case. We see the occlusal plane in the denture, and we see like there is a very less space, interarch space, in which there is no space for the prosthetic. Okay, so in that we discuss and we finalize, we do a bone cutting, and then we place the implant. Okay, so like we get a sufficient space for the prosthetic. But the question is that how much we have to cut, where to cut, and the third portion is which is more I have to cut from the occlusion, like upper more or lower more or equal I have to cut. So many questions are that, and we plan it, we digitally see, and we decided like according to the bone, the white color as you can see on the screen, upper we require very less cutting, but lower we require more cutting because of the occlusal plane is according to the reference of occlusal plane. And the interarch space what we have decided like 14 to 15 mm. Okay, for the perfect prosthetic, it means it should land up in 10 to 15 mm category. Okay, so that's how we have planned it in this case. So this is a bone flattening guide, then the drilling guide on the top of it, and you as you can see we have there is a mounting, upper and lower is mounted in the software. So like the denture what we have used to send us is we have used as a mounting, so mounting of bone. So my prosthetic also ready before surgery, so everything is ready before surgery. So on a day of surgery, just give a like, open the flap, place the guide, as you can see the axis board, we cut off the axis board, then we place a drilling guide on top of it with a screw tape, then we do a drilling. So you can see very easy, I'm not holding the guide, nothing, it's very steady guide and easily finish of the things. And you cannot believe it, from morning 9 to evening 10, or morning 9 to evening 5 or 6, he has finished up the complete case with the prosthetic. So this is the implant session. And then after implant placement we place the abutments on top of that cylinders. Then we pick up the cylinders, uh, cut off the extension. After pick up, we reinsert prosthetic. And this is the post-operative OPG of the case. And this is the 6 month follow-up the case. As you can see, we done a bone flattening and we given the profile. You can see the backside profiling of the prosthetic. So the same profiling we got after healing. So there is very less food lodgement or anything in that area, and everything is completely according to our profile. So this is the advantage of planning of the prosthetic before surgery. Now the condition is of me is like this because after doing the single arch, single implant, sectional, then the full mouth, full arch, doctor is like we want the same kind of solution for zygomatic implants. Okay, and if they will get the answer, okay, then he is the hero, and if they are not getting the answer, the catch is in my hand. Okay, so that's the things I was land up in this condition. So I took, okay, we'll take this challenge and we'll go ahead with this. So my implantologists, especially oral surgeons, are more happy for this kind of workflow. So we created this visually regulated zygomatic guide. So in which like you can place the implant and the prosthetic also in the same appointment. So I'll just explain the part of the guide. It has a two parts. One is lateral drilling guide and second is final drilling. So open the flap, place the guide, okay, and start the lateral drilling. So after lateral drilling got over, you will get a tunneling of that in future implant. Then is screw it in the top part, so now it become a ring. Okay, then you can insert the drill and start drilling it. Okay, so after drilling you can take a implant and you can insert the implant through that complete well. So like you will get complete path of insertion of that. So path of insertion of that. So like this you can insert the implant, and then you take out the top part, open, and you can see what we have done and we achieved. So like placement we got the answer. Okay, after that we we have some challenges, like example is you can see the long drills of guided implant. So when we are doing the placement of the on a molar area, okay, we have to start my drilling from here. Okay, it's very difficult for the patient to open the mouth from this much of length posterior area, and antagonist did already with that, it's very difficult. Okay, so we modified our protocol because we want something which is resting like this and you can pull my zygomatic implant into zygomatic bone. Okay, so we created this guide in which like the lateral drilling the same part, but the top part we shift my drilling entry from here to here. The top part we take it and we create a special drill for that. So like my top part will go inside of that and we can start drilling of that. So it will go inside of that and we'll start drilling. So I can almost 15 inside of that. So like mouth opening, I don't need much for the posterior area. The same way, in this case, the same protocol use lateral drilling, and but the prosthetic also ready, and it is connected to zygomatic implant one each side and anterior conventional implant and the prosthetic on the same appointment. So this is a same lateral drilling guide and the final drilling guide, and the temporization that is also metal acrylic which is ready before surgery. So this is Dr. Neil Patel and the team. We are doing so many things together. So on the day of surgery, we just open the flap, place the guide, do a lateral drilling, the final drilling, insert the implant. So right side and left side implant we got it. Then one more guide for anterior conventional implant. Place the conventional implant. But in this we have done some modifications. Okay, it's called a star abutment, in which we can modify the abutment on the chair side. We can customize multi-unit abutment on the chair side, which like normally multi-unit have a six hex, so you can rotate on six direction. But in this multi-unit we can rotate my abutment in 24 direction. Okay, we converted internal hex to external star, so you can rotate my abutment in 24 direction, and the center part what we have, which is how we have different angles, so we can get example. We have plan 17 degrees, so we have 15, 20, 22 like that. So we can select the best angle and we can finish off the case. So same, we have used the star abutment. So anterior implants all are going to be not 17, not 13. In between angles are there, which is not provided by the company. So we customize the abutment after placement of implant, because what we know before surgery only, my implant is not actually 17 or actually 30. So according to that, we have planned the case and we customize the abutment on a chair side, like on a day of surgery. And my all cylinders, as you can see on the screen, is parallel. And then we pick up the cylinders at routine way on metal acrylic prosthetic, you can see on the screen. And then we cut off the extension and reinsert. So everything like zygomatic implant placement, the abutment, the prosthetic, everything we can finish off the things on the day of surgery on the same abutment. So that's how we can take advantage of digital dentistry with the long-term prosthetic. In the same way, I already explained, like the final we can scan it, the prosthetic or the jaw relation, and you can create the prosthetic for the case, which I already explained the previous part of this presentation. This is a case, and we got this final result of that case. The two implant which is not loaded, it was placed in 1996. There is no component available in the market for that, so we thought we keep it as a sleeping. We don't want to disturb that, and remaining can finish off with the prosthetic. So that's how we got this done in this case. The same way, the case in which like you have quad zygoma, like you have four implants, okay, and you can see the anatomy. This zygoma bone is little up than this profiling, and little wider the angulation. You can see on the both sides not equal. Okay, so according to that anatomic structure, we have planned the quad zygoma. Okay, so everything is ready, like the drilling guide prosthetic as you have seen the previous cases. Same way, like day of surgery, open the flap, lateral drilling, final drilling, implant placement. But in this, when we plan it, we know like 52 and 60 degree available from the company, and uh, we have different angles. Okay, it's not permit us the 50 and the 60, 52 and 60, as well as the correction is not in one direction, correction in two direction, buccolingual as well as mesodistal, because anterior implant is like mesodistal and buccolingual both angle. And for company but only one angle abutment is there, so I can only correct one angle. So that's the problem we notice. And but in this case, the abutment, the doctor don't want to do a customized abutment, so he want to do a company based abutment. So we have used the company based abutment, but you can see the all have different direction. Okay, you can see the direction of all implants not parallel. Okay, because the maximum availability of abutment from the company, they have used it, and we have different angles. So as I told you start of my presentation, the pathfinder, so we have used the pathfinder concept in this. Since I will let you like teach you like the brief about that. So if you have this kind of condition in which you have to create the bridge from premolar, molar and the molar, so what you will do, you will create the path of this like this. You cut the tooth, or you can create the same path, or you can make a telescopic and same path. So like you will get single path, and as well as your finish line should be parallel. So like you will not get the wobble, as I told you in the previous part of my presentation, which like abutment is also parallel and the finish line should be parallel, both should be parallel, then you will get the passivity. So the pathfinder, what they will do, example, in the same case we have multi-unit, but it is not parallel with each other. Okay, as well as the angle, the finish line is also not parallel. The path of insertion of this implant is this direction, and path of insertion of this implant in this direction. So pathfinder, what he will do, I want this path, but I'm getting this path. The pathfinder give you the common path of insertion of both, mean value of both. So now, if it is not there, if I fix this process, the other part will adapt on tilt in this side, and if I insert the screw, I will get two or three rotation. My screw will stuck, and one part of my screw is touching, and other part is not touching, and because of that, long term it get fracture. And if you ask the doctor like why got fracture, he will say like it's a thin screw, na, so it got fracture. It's not like that. It, as I told you, like you should think why it's happened. Okay, so because of this reason is going to happen. So what Pathfinder is doing, it give you a common path of insertion. Now if you can see, everything is resting, okay, and the path of insertion is here. So it will transfer all the forces to the implant body and avoid the fracturing of the screw. Okay, so that's how we place the implant. So in this we use a pathfinder. So as the pickup prosthesis is ready, we use a pathfinder. The cylinders are ready as we have planned this case before surgery. So cylinders are ready, and we pick up and reinsert the prosthetic. So this how we have finished on this case completely. So you can see the all four implant have this part and the lower have this. So this is a final prosthetic of the case. This is a delivered after delivering of OPG of the case. So my implantologists are so much of happy, like as you have seen the screen, because implant placement, prosthetic, everything is much easy with the digital technique. So now they are doing a lot of cases with the help of me. So that's how the things are working in the digital dentistry. Now just little brief about the next level of this is reconstruction part, in which there is no bone for zygomatic implant, the maxillectomy. So it's called customized implant, and this is FE analysis. So there is no much difference in the uh, stress. If the stress will be coming on this, it's going to be same. Okay, but the movement, the flexibility. Okay, if it is going to be there, the zygomatic implant have a less resistance than the PSA customized implant. So the condition in which we have less bone, yes, definitely customized implant is the better option for that. And along with that, this is a one abutment called OT equator. So it has a cylinder like overdenture, like the ring, like overdenture the ring and the screw. So advantage of overdenture as well as fixed prosthetic. So overdenture will give you the stress breaking as well as fixed solution. If you looking for that, then is the OT equator is the better solution. So what is the difference between OT equator and the normal multi? If left side you can see there is no stress breaking, okay, and the right side there is a stress breaking in between. So when it is going transferring the forces, it will not transfer exactly to the end of the product, like the onto the implant. So it have a stress backing in between. So the case of maxillectomy, which right and left customized implant with the equator abutment, the bar is ready before surgery, and the prosthetic. Okay. So on the day of surgery, like open the flap, place the implant, right side, left side, place the bar, but don't fix the implant with the bone. After fixing the prosthetic, fix the implant to the bone. So like they have a reference, and after fixation you open the bar, close the flap and reinsert the prosthetic. So this is the case in which we can after healing of that, and there is a lot of publication of us on it. You can go through it on oral maxillofacial journals. The same way, as I already explained, the digital obturator also we can do it with the help of this technology. Uh, then this is a unique case I got in which the obturator is required. Okay, so it retrieval prosthetic is required, but the three zygomatic implant is already there, and it is hanging onto the zygomatic bone. Okay, there is no maxilla. Okay, so it's, I can say it's a cantilever from the zygomatic implant, zygomatic bone. So if I'll get less forces at the tip of the abutment, it will create a lot of forces at the end of my junction of the bone where it's osteointegrated. Okay, so if every day patient is wearing the denture or treating the denture, it have a lot of forces. As you can see the table, okay, the table base, the pillars have, you can see it's moving when the taking out the denture. The same way zygomatic implant also transfer the forces, and that's the reason it's maximum times got failed after healing also. So in that we have developed a special prosthetic. The attachment is from Britain. It's called pin prosthetic. Okay. How it works? So it's a pin like a mobile. Okay, mobile slots. Like if maximum people are using Android phone. Okay, so they have a slots to press the pin. Your slot will come out. You can place a SIM card in that, and you can just drag it inside and you lock. So same way you require the pin to open the denture, and to wear the denture. So this is the bar, and this is the obturator, which is hollow from inside. Just I will tell you the part of this. So this is a bar in which there is a hole and there is a lock and pin. So you can lock the pin and you can take out. So how it's work? So this is a bar on which like patient has to wear it. So my bar is fixed onto the implant with the screw retake, and now like this, just patient have to lock. They push it, so it so now it's locked with the bar, so it will not move. Okay, so while wearing, there is no pressure forces onto the implant. Okay, and the same way when patient want to retrieve it out, there is no need to snatch it out. Okay, it's just you push it like this, so all pin will come out like this. So all four pins. So now it releases easily come out. Okay, so there is no negative forces while retrieving the prosthetic. So this is a case, it's a bar, screw it in bar, and this pin written obturator on top of it, and smile of the patient. So how to wear it? So it's easily wearing like this, pressing, and like pin. So it creates spatial slope. So patient just press it over there, it already will glide and go inside of the duct like a golf. So it come out easily. And the post-operative OPG of the case, as you can see, the hollow obturator extension completely inside of this cavity. The same way, partial mandibular case in which like you have a lot of height from occlusal plane to the bone. Okay, so it's crown to ratio is differ when you are planning the prosthetic. So in this we plan the implant, the guided surgery. We use a special implant in which like half of the area is covered with the implant body, and then my prosthetic part will start. And this is my prosthetic what we have designed pre-operatively. So this is a special implant in which half of the implant is polished. It's from the noise, the cortical implant. So we place it this implant on some bone, and half of the interarch space is covered with the implant and half with the abutment. So my crown tooth ratio will not alter, and the fulcrum of my lateral forces will have onto the small screw which it is very nearby that. So it's avoid the screw loosening of the prosthetic. So this is how the implant placement immediate prosthetic we have placed, and this is a prosthetic. The same way, it's a unique case. The customized implant we have very less board. I just show you. So implant prosthetic everything is prefabricated before surgery. So this is the clinical condition in which there is no attached ginger because past completely mandibulectomy is like partial mandibulectomy is there. And cross section we have very less bone like this. Okay, so we don't have any scope to place a normal convection implant. So in that's how we have created a customized implant in which we have there is a horizontal screw to stabilize the implant and the vertical screw from the top of that. So this is the bone cutting guide. So my implant is down than the crest, so it will not create the problem of exposure of implant. As the subparastral implant problem is exposure of implant, so we can avoid that. So it's a cutting guide, and that cutting guide slots are there in which my implant will place. So this is the implant, and on the top of implant there is abutment. From abutment we have one more screw which is going to the abutment. We connect implant to the bone like this. Okay, and then we close the abutment. So on a day of surgery we open the flap. Doctor place the cutting guide, create the slots, to place the implant on that slots, and the fixation of screw from the abutment part. So vertical and horizontal both lock we have, so my implant will not work. And from right side to left side it's also connected with the bar which is ready before surgery, as you can see. And then we close the flap and insert the prosthetic. So that's it on a day of surgery. And this is the post-op 1 month and 6 months, and now we almost finished the 4 years of that case follow of that case. So this is a unique case in which like we have a very less bone. So horizontal and vertical, as you can see the vertical engagement of the screw with the bolt. So that's how we can do a reconstruction of this case. So thank you. Before ending my presentation, this is a message. Okay, you should get married with a perfect woman, or you should know everything inside of your technology. Otherwise, you will do this. Okay, so before going anything, this all platforms are there. You should follow all the inside of this platform. You learn and then you apply the things. And for the implantology, this is a small story like the race. If you slow and study, win the race. But second, third, fourth part of this story is most important part of that, because like the first part, all tortoise won. Okay, so rabbit have ego. They have planned one more race. Okay, now the second part, rabbit won win the race. Why? Because he learned from his mistakes. So implantology always do a learning from that mistake or other mistake. Okay, the third part, like tortoise also got ego problem. He has done a race on this track, so there is a land and the water. Okay, so always up and downs are there, case are there, so you have to make the strategy according to your strength. What you can able to, you do it, or you make a group, or you can modify the thing, or you can learn the things. Okay, and the last part is most important part of implantology is teamwork. You should teamwork with your lab, with your implant, the planner, or with your surgeons, or with your periodontist, or everything, and then you do a work that is much better part in term of implantology. So thank you for listening me. Thank you for giving this opportunity. And this is the assessment. Thank you.
All right. Thank you so much, Doctor. It was a great presentation with, relevant cases to correlate better. So I hope all the participants, they understood better. And you were quite specific. It was very informative.
Yeah, thank you.
Yeah. So meanwhile, I request all the attendees, if you have any doubts regarding the presentation, drop in your questions in the Q&A box below so that it can be addressed. So, before we take up questions, I would like to give a brief about our organization, Dentist Channel Online. I'll be sharing my screen right now. Right. We are India's first digital dental media, and we stand strong with the motto Healthy Smiles, Wealthy Lives. We offer multiple services for dental students, professionals, dental organizations, and businesses as well, catering to all your academic and professional needs. You're most welcome to visit our website www.dentistchannel.online for insights of each of the services we offer. And we have conducted more than 1,000 live dental webinars and more than 50 online and offline workshops with 50,000 plus participation certificates issued. You're most welcome to be with us on our upcoming webinars lined up with some interesting topics. And you can subscribe to our social media pages on Instagram, Facebook, and YouTube for getting all the latest updates about the dental webinars, workshops, courses, dental news, and events. And I request all the attendees to become our Prime member to avail the added benefits of getting a certificate of participation after every event and for getting special offers on the dental courses and workshops. So, we have a few questions, Doctor.
Yeah.
So, the first question is just give me a moment. Okay. Which software is better to design surgical guide for dental implants?
To be
Could you
honest,
mention the example?
yes, so to be honest, like all software is fine, but main thing is like you should be thorough the knowledge how to use the software. Okay, in term of me, like I'm using Exoplan because I'm using a ExoCAD as well, and maximum
Mhm.
lab are using a ExoCAD for the prosthetic design. Okay, so it easy when you want to plan in Exoplan, so you can design like example smile design, anything you want to do it, you can do it in ExoCAD. You can take complete data into the Exoplan and you can plan implant accordingly. So it's connected with the lab. Okay, you want to design the prosthetic after implant plan, you can design in the prosthetic. So that's how I recommended you should go with the exoplant. So like you have more connectivity with your lab also.
All right. The next question is CBCT or CT more accurate for assessing the buccolingual dimension of bridge before implant replacement?
Yeah, so it's a good question. It's a long talk on that. But to be honest, for normal cases like one implant, two implant, three implants, it's fine. CBCT and CT scan, there is not much difference in that. But if you are looking for atrophic cases, like you have a sinus lift because there is no bone, or you are going for zygomatic implant or pterygoid implant, yes, I will recommend a CT scan because CT scan will give you a thinnest part of that also. Like if it is subperiosteal bone is there at the bottom, like if you open the flap, there is, you cannot directly see the sinus. Okay, but if you see the CBCT, now you will get a window in that area, but practically it's not a window. There is a some thin layer of subperiosteal bone is also there, that you can get it from CT scan. So the condition in which like you want to see the atrophic region and it's there, you I will go for the CT scan. Because not all cases, because in the CT scan you have radiation exposure is more, so in that it's not that much of required. Okay, when you have regular cases like single teeth, multiple teeth are there, so it's the things. But yeah, accuracy wise CT scan is much better than the CBCT.
All right. The next question is for the guided dental implant placement, which type of surgical stent do you prefer, 3D printing or milled one?
Yeah, so the good question. In that, I will prefer milled one. But you know what? You cannot use that guide for all cases. One implant, two implant, you are parallel. It is parallel. You can plan it. But if you are all on for like tilted implant and all, you cannot able to mill it. Okay, so because like all have different direction, and milling machine cannot allow to do that milling of the all different directions. So best thing is printing. Now the printing have a problem is you will not get exact dimension of inside of your sleeves area. Okay, so what you can do it. You have a three option. One option is like you do a 3D printing. Okay, and you calibrate it, and then the software have provision to modify it. Okay, modify your file. Example, your sleeve is 0.5 mm smaller than you required, so you can create the hole 0.5 mm wider in the inside of software. So after printing you will get exact hole. Okay, second thing is like that's the reason the most of the company give metal sleeves additional, so like you can loot it on top of it. So like they will give us bigger sleeves and you can loot that sleeve, so like you will get the perfect solution. And the third one is like what we are most commonly used, it's called make and mill technology. Okay, in which like 3D printing followed by milling. Okay, so advantage of printing as well as advantage of milling, both you can take it. And yeah, on an average, if I'm printing doing a printing of 50 cases, okay, in that this kind of technology we can 20 to 23 cases I require this kind of technology to fabricate guys, when especially in full arches cases.
All
So
right.
this is the thing.
The next question is which software can we use for smile designing for mockups and treatment planning?
Yeah, we have, see, one more thing I want to tell you. The software question you have asked is good, but you know what? In market, you have a plan, smile design 2D software also and 3D software is also. Okay, 2D just impress the patient. Like you take a photograph, just they will give you a smile and just finish off the things like patient got impressed and he is ready for the smile designing. But to be honest, you buy the 3D software in which like you scan or take a cast of the patient inside of software, then you plan a smile design. It is much better. And in that also nowadays we have face scanner also, so you can see the front profile as well lateral profile both in inside of software. Okay, and then you show it to the patient. So in 3D planning we have a 3Shape and exocad both software. Most commonly we are using exocad because third like compatible with all third party softwares like for milling, because you have to think after designing you have to go for 3D printing or milling and all for the manufacturing point of view also, so it's more compatible with that. So I'm mostly of the time using the exocad for that, and always it's 3D. Okay, 3D planning.
All right. The last question is immediate, and delayed implant placement. Which one is superior over the other?
If you ask me in this case which is superior, then it is much better question. Okay, so the condition, like the condition which allow you to placement, like if you have healed socket, like everything is healed, like patient is 2 or 3 years of, there is no teeth and you have much good bone, you can directly place for immediate loading. For delayed loading, when we are doing, especially when we are placing the implant in the half arch, okay, like example, my half of the teeth are there and half arch is like my completely edentulous, in that we are not doing immediate loading because of the lateral forces, there is no resistance forces from other side. Okay, so there is a chance of implant failure. Okay, that is a one condition. The second condition in which we are not doing the immediate loading, in which like patient is not, that I can say the occlusion is not properly given. Like before planning, we create the denture, okay, and is the centric is just searching for the having the food. Then we are doing for a delayed loading. Okay, other condition in which like we extract the tooth and there is no bone. Like if we virtually extract the tooth and after that there is no bone for the primary stability. Like I don't have a bone for 2 or 3 mm also. Like 5 mm actually we require minimum to get a primary stability. If I am not getting that much of bone, I will go for the delayed loading. And the fourth condition which like I have done a grafting, like Curie technique or anything, like I took a graft for somewhere and I got a torque very less. Okay, in this condition I'll go to delayed loading, but remaining condition we can go to the immediate loading.
All right. There's another question, doctor. What is the prognosis of direct maxillary sinus slip followed by immediate implant placement?
Direct sinus will depend how much the bone you are getting it and which kind of bone graft you are using it. Okay. Uh, for that we are doing immediate loading, but you know what is the technology, the level of the technology is like what right now you are doing is the lifting the sinus and you are placing the direct material of bone grafting and then you are insert. But for the down in like the crestal layer, you require 2 to 3 bone at least to get a primary stable of your implant. Okay, the second thing, when we are doing the immediate loading, if we have less bone also, in with the condition which we have one more option of to customize the bone block. Okay, we customize the bone block according to the sinus cavity. We place the bone block from the window and then we start inserting the implant. So implant itself engaging the natural bone as well as bone block, so it lock the bone block and then we do immediate load. So that's the condition, otherwise we avoid immediate loading in direct sense.
Okay. There's another question. What is the best option for increasing lower denture stability in total edentulism with less than 5 alveolar ridge width?
Means regarding of implant supported or regular. Okay, I will go through it. So example, if you have a very less height, so definitely you will not get a stability of your denture, so you have to go to the implant. Now implant have two options, one is fixed option and one is removable. Okay, for Indian scenario we try to give a fixed option first. Okay, but it depend antagonist. Example, we have a very less bone, like mental foramen to mental foramen also only we have bone, and antagonists have a natural teeth. Okay, so what we'll do all on four and give a premolar to premolar, like molar to molar occlusion, but second premolar is skip from the prosthetic. So in place of 12 teeth we plan only 10 teeth. Okay, and give a fix. Okay, the second option is like overdenture. In overdenture, if we have we want to go, so minimum 3 implant we place in place of two. Why we avoid the two? If we have a two implants, okay, it's act like a door, one side is connected, other side is moving, so patient always have complaint on back side. Okay, the itching and all, you trim it the denture, you have more complaint about that. So if you have three now, so it avoid the movement and it will create less movement of the denture. So 3 implant we place for the overdenture or locator or ball socket, we are going for that, and the bar supported we are doing. So that's a two option we are doing.
All right. There's another question, doctor. What is the best way to achieve emergence profile in dental implant restoration?
For emergence profile, we can create one more webinar, but shortly I can say the condition, three condition is there. One condition is like extraction is remaining and you are placing the implant. Second condition is that extraction remaining, you place the implant, but you cannot load it immediately. And third condition is that like you there is already extracted, so there is no emergent profile and you want to create. Okay. So first condition, you want to extract the tooth and you want to place the implant. So you can use the same like immediate temporization as I saw in one case in which we have the partial extraction, we place the implant and we get that complete profiling of that. Okay, in that also if you have coronal part of the tooth is intact, okay, then you can use the coronal part of that as a crown. Okay, you can make a abutment along with that. There is a one technique. The second option is like in which like you cannot load it immediately. You extract but you cannot load it immediately, or delayed loading you want to go ahead with that. Okay, or already extracted and you have to go for the delayed loading kind of that, because already emergence profile is lost. So what you can do, we plan it inside of software and we created the future crown as well as, okay, with the using of adjacent teeth, okay, the profiling and everything. And on a day of surgery we open the flap, we place the implant, we place the crown, and then we close the flap, okay, onto the crown. So the crown will supported by the soft tissue na? So soft tissue will give that profile and it healed up. The same way example, you have molar, okay, you want to extract the molar and you want to maintain the same emergence profile of that. So before extraction of molar, we what we do, we'll take a coronal part from the software and we create a crown before surgery according to that, and then we plant the implant. So we extract the two, we place the implant, immediately screw the prosthetic, and then we suture the soft tissue from interdental area and then allow it to heal it up. Okay, and we use a degradable suture, so it automatically degrade, and after the 3 months, we just when you open it out, you are completely profiling like what you are natural. So that's how you can do it.
All right. I guess that's it for the questions, Doctor. Thank you for answering all these questions patiently. And do you want to add in like a takeaway note?
Yeah, so I already spoke like you require teamwork. Okay, without teamwork,
Mm.
implantology is nothing. Okay, you need a oral surgeon, you need a prosthodontist, you need a periodontist, and at the end, the BDS to generate the case. So everything is compulsory. Okay, in this scenario. Thank you.
So it's basically like a multidisciplinary approach.
Definitely, 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 definitely.
All right, doctor. So it was wonderful to have you on board with us. And with this note, we'll be ending this session. And thank you to all the participants. And once again, thank you, Dr. Anshul, for being our
Thank you,
guest speaker today.
thank you for giving this platform. Thank you.
All right. Bye bye,
Bye,
doctor.
bye, bye.